I thank the Uttaranchal Orthopaedic Association for inviting me to share my experiences on the PIP joint injuries. We have just recently gone through the cricket season, and these are, after the distal radius, I think all of you will agree that these are the commonest injuries of the hand. And the problem with these injuries are they are frequently missed for the simple reason they are frequently missed for the simple reason that probably a proper history is not taken. Everybody says cricket ball or some injury has occurred. The commonest reason of the PIP joint injuries also is cricket ball or some twisting injuries. Currently, bikes are competing with the cricket ball for the PIP joint injuries. You get various appearances of the PIP joint injuries like this. So, but due to constraints of time and what I have been told to be my brief, I think I'll restrict myself to PIP joint fracture dislocations, blunt injuries with the PIP joint, and some talk on PIP joint dislocations. We'll not go through the articular injuries and all that because that is going to be very time consuming. So for PIP joint injuries, one must take a proper history as usual and suspect, depending on the clinical examination, you suspect that there is a problem. And the mainstay of diagnosis or how not to miss a PIP joint injury is the plain X-ray. A plain X-ray is probably the most important thing, as you can see in this example of an orthopedic surgeon. So clinical examination, you can see that there is a bruising, there is one finger which is involved, the finger is not able to flex properly. And you can see multiple X-ray views. The problem which I have seen in practice, or the reason why these injuries are missed, is that X-ray is taken of the hand. And to take an X-ray of the hand and X-ray is written of epilateral, one should always write an X-ray of that involved finger. You say X-ray of the middle finger, epilateral oblique, or multiple obliques, multiple lateral views. That's not going to be costly, but concentrate on that finger. If you take an X-ray of the hand, you are likely to miss. So take multiple X-rays. There is really no need of CT scan. Zoom the X-rays properly, and you can diagnose it properly. Now, this is another case where there is a sports injury. The patient was having minimal pain. You can see hardly there is any deformity of the finger. But the finger is unable to flex, and you can see swelling of this finger. Plain X-rays were taken. Unfortunately, a lateral view was not advised. So the seriousness of this injury, one can obviously, if you see this X-ray in detail, you can see that there is something wrong here, but you really don't know what's wrong with the finger actually. So the diagnosis can be missed by these random views, and you take a dead lateral view. In fact, I asked the radiologist to take two lateral views, one from the medial side and one from the lateral side of the finger, and your diagnosis is perfect. Like this, a dead lateral view is essential for the diagnosis. And you can see that this case, though it looks like a dislocation, is not a pure dislocation, it's a fracture dislocation. Now for this, the treatment is different. You can see that the articular surface of this joint is very intact. And since the patient fortunately is presented acutely, the treatment will depend on the time since injury and the articular involvement. So you can see that sorry, 1 minute. Yeah, you can see that this articular surface is quite really intact, and this volar flake is there. So there is a volar lip avulsion, and which is a dorsal fracture dislocation. So these injuries can be treated by closed means. You may or may not give local anesthesia depending on the patient's pain perception and status. And all these injuries are basically stable in flexion. So the amount of traction that you require to keep these fingers in flexion is variable. It depends on the patient cooperation and how motivated the patient is and how well you understand the problem of the patient. So it all depends on the time elapsed since injury and the articular involvement. Now, like this case, the articular surface was nearly normal. So it will be very stable. So this traction in flexion is, or keeping the finger in flexion for 2 weeks is more than enough. The volar plate heals significantly enough for the patient to start actively extending the finger. And you can see that the patient is able to actively flex the finger, but is not able to actively extend. Okay, no problem. So we want the volar plate to heal. It will always heal in some sort of flexion contracture. and you can see that the articular active extension is not complete. So it doesn't matter. So at 6 weeks, you reassess the patient. You take an X-ray in flexion and extension. You will know that the joint is stable enough. And then if the patient has developed a flexion contracture, which he will invariably develop, you can give a Kepner spring splint for initially for intermittent use, and then you use it at night. Teach the patient how to use a Kepner splint. See that there is no vascular problems or no pressure problems at the fingertip, and then you can get a very good result. So basically, it all depends on how well you can maintain the flexion. There are various ways of maintaining the flexion. Like this case, again, you can see that the articular surface is much more involved than that, but still you can see that there is a good amount of concavity here. So there is a good prognosis if the patient has presented early. Even within 8 days, if he presents, you can treat this with traction. Now, in this case, a traction was given in a different way. I currently don't prefer this method because this Velcro can hurt the fingers, and I don't prefer this method. I'm just showing it because I used to use it, but I don't prefer it because the Velcro hurts. You require traction for 15 days and you can have skin problems. So at 6 weeks, there is a flexion contracture. So Kepner spring was given, and that is the result at 3 months. So, however, many times the reduction seems to be stable, but the surgeon forgets to keep the finger in adequate flexion, and then you develop this sort of problem. The patient had a very good close reduction. The joint is very stable, but patient unfortunately does not have further flexion at all. So what do you do in this case? A simple splint has been designed for this, for passive stretching of the finger like this. And you can see that this patient is actively flexing and extending with the splint on. And you can see a very good result. So occasionally you develop an extension contracture of the finger, for which this splint works very well. So now, again, this patient has presented within 8 days of the injury. And this was again an orthopedic surgeon, the same patient which I showed you first. And he refused external fixation, but he also refused open reduction, but he was not sure whether he'll be able to maintain the finger in flexion. So I had to not only do a close reduction of the articular fracture, I had to put an extensor block pin in this case. And this was the result at 1 year post-op. And that is the X-ray at 1 year post-op. Even here you can see that I have taken multiple X-ray views. A single finger X-ray zoomed properly, gives you a proper diagnosis and proper picture of what is going on. So now this patient presented at 12 days. Now this is the time between 12 to 15 days where you can be, you may require, this patient may require surgery or may require open reduction, may require some other methods, but you can give it a try depending on the status of the articular cartilage. So again, in this case, you can see this AP view, this oblique view. This is not really telling you much. Now this is the lateral view which we took, and that properly zoomed lateral view, you can see, if you can trace the articular surface, you can see that there is a good amount of concavity here. So if you can get a close reduction, you can still manage this without surgery. So nowadays I prefer to use this tape on the finger. You can see the status of the vascularity of the fingertip through this, and you can use this tape and give a heavy traction on the finger. You should not use on the nails because the nails can get painful. So I give a traction on the finger. You stick the tape with tincture benzoin into the dorsum of the finger and maintain it for 2 weeks. Invariably, they will develop a flexion contracture because not only you have kept it in flexion, but there is also an articular injury. And this, you can see this picture at 6 weeks. This is the flexion and extension views. The patient does not have a complete extension, obviously. And then we gave him a Kepner spring splint. Before this Kepner spring, this was the amount of extension he had. And this is at 5 months. You can see active flexion on the X-ray, active extension on the X-ray. And that is the result of the patient after 5 months of the injury. So now this patient presented at 3 weeks. At 3 weeks, unfortunately, close reduction is not possible. This patient presented way back in 2000. And in these cases, I prefer to use a ligamento-taxis method, which you all, I think, have seen me presenting in some or other conferences. And so this is a very simple method. You use a 1.5 millimeter K wire on the middle phalanx and proximal phalanx. Try to go preferably bang laterally. That comes with practice. This was the result of this same patient at 1 year post-op. and this is 16 years post-op of the same patient, and that is the result at 16 years. So actually, if a patient, even if he presents late, if he presents within 3 weeks or 4 weeks, you can get a very good result with ligamento-taxis. Only thing is you have to, while at the time of removal of the traction apparatus, you make sure that the articular surface is very congruent, as you can see in this example. Now, this patient presented 6 weeks post-injury. Now, various options can be offered in this patient, like volar plate arthroplasty, hemiamate arthroplasty. But what the experience which I have had is that though this fracture looks malunited, actually in principle or physically, actually it's not united at all. And the volar plate being so strong, if you can use a heavy traction with external fixator on this, the fracture gets undone. As you can see, this is the initial X-ray. Also, with this method, you have to ensure that the patient does active extension and flexion of the DIP joint. Obviously, you cannot move the PIP joint in this method when this treatment is going on. It lasts for about 4 weeks. And you can see this serial X-rays. You can see about 3 to 5 millimeters of traction is required. You can note in this X-ray that the fracture which was seemingly united has got pulled out and it is undone. So this is an immediate post-op X-ray. There is no need for serial traction or I would say gradual distraction. You can distract it on the table, and you take X-rays at 2 weeks and 4 weeks. At 4 weeks, when you take an X-ray, remove the distractor and just keep the pins on, and with the pins on and with the distractor out, and take a dead lateral view. If there is no subluxation, that means that this thing has healed, and you can then remove this trans wires which go through these bones. And that is the X-ray at 6 months post-op, and that's the function of this patient at 6 months post-op. You can see a very well-formed volar lip, only by traction, no surgery was required. Even you can go up to 3 months. I'm presenting the example as it is an interesting case. This patient presented at 2 months. He was a fire officer. So you can see a seemingly malunited volar lip fracture with a dorsal subluxation. Patient has no flexion of the PIP joint here. He already had a mallet finger, untreated mallet finger of the same finger DIP joint. So this was the initial X-ray at 2 weeks. You can see that this, because of the traction, this fracture got pulled out, and you can see this bone is now realigned. You can see that the articular surface is quite well realigned. It's not united yet. This is at 4 weeks. The fracture is united, but unfortunately, there is still an element of subluxation on the board of this fixator. So you, in this case, you remove the fixator, but you don't remove the distal pin. So the distal pin is bent like a bent like a U on both sides, and then I apply a rubber band and just give traction for further 2 weeks on the same finger, so that whatever collateral ligaments had got stretched, they will become, the finger will go back into flexion and the joint will get reduced. So at 6 weeks post-op, the dislocation is reduced. There is no V sign, and you can see that the fracture is already united now in good position. The articular surface is congruous, and you can see that this volar lip is good enough to prevent resubluxation. So this K wire is then removed, and then patient is treated based on the amount of flexion contracture. And then I always, as I've said, that I take an X-ray in flexion and extension to see how much stability is there or whether there is any element of subluxation remaining. So this was a very good result at 1 year post-op. Again, you can note in this X-ray that the K wire is put dead laterally in the finger. For this, it requires a lot of practice, I can say. And you have to remember that the two things you have to remember, that the bone is shaped like a D. It's not a circle. So all the middle and proximal phalanges are D-shaped, and you have to insert the pin in the dorsal half of the finger, not in the volar half. The bone is on the dorsal half of the finger. So if you remember that, your external fixation can go on very smoothly. So this is the result at 1 year. Now this patient presented at 6 months post-op. Now I'm sure, looking at this X-ray, with this fracture is completely united. I know that this cannot get pulled out with an external fixator. There is no fracture line also seen. So no treatment was taken by this patient. Patient did not have any flexion of the finger. So now this patient can be offered a hemiamate arthroplasty, which is very popular. This patient can be offered a volar plate arthroplasty, but somehow I'm not comfortable with these two methods. They give a lot of problems. So this is the status of this finger on presentation. So I opted to do an open reduction by the shotgun approach. I open reduced it. I identified that volar lip fragment. I did an osteotomy. I brought the piece down, obviously with the help of C-arm on the table. And then I did an open reduction and fixed that fragment with a 1 millimeter screw. And obviously in this case, the joint is so unstable on the table that you have to put an extensor block pin. So this pin was put, and that is the X-ray at 4 weeks after removal of the pin. The joint is stable. It is obviously in flexion contracture. And this is the C-arm images of flexion and extension of the same finger at 6 weeks. Still, it requires a Kapner splint to stretch it out, but you can see that the articular surface is now very well restored. And that is the function of the finger of the hand. This patient is an engineering student. He's taken these pictures and sent it to me on WhatsApp from his hostel. And you can see a very good flexion extension. You can see this very well healed scar also now. And that is the Kapner splint that we give. In this case, I'm slightly scared of the articular because we have opened up the joint completely. So I give a Kapner splint at about 2 months. I don't give it at 6 weeks because the splint is very strong and it can, if the articular or the ligaments are not healed well enough, then they can subluxate the joint. So that is the video of the finger in function. This is, I think, taken about a year or 2 years later. So now we come to another very common injuries of the PIP joint, and that is the blunt injuries. Now here these injuries are very tricky actually. On paper or on, I would say, on the X-rays, no fracture is seen. So generally these injuries are branded as trivial. The X-ray is normal. 90% of the time these patients don't come on the first day. They don't go to an orthopedic surgeon. They don't go to anybody. They treat it at home by some sort of local therapies. Some intelligent ones apply ice, the other ones apply heat. And then these are the most neglected. Even in fact, these are more neglected than the fracture dislocations. And they invariably land up in flexion contractures. And they always present when the contracture is very well developed. And these contractures can be very disabling. Cosmetically also, they are not very pleasing. So now this is one example which patient presented fortunately to very early. And you can see that this patient has got full flexion. The very fact that they have got full flexion, most of the time they don't take treatment because of that. They just regard this swelling as insignificant or this injury as insignificant and they don't treat it. But if you take a dead lateral view, you can see that swelling. And this swelling means that the joint, there is some hematoma or some collection in the joint and this extensor is going to be weak. So these injuries, these fingers are likely to or most probably going to develop a flexion contracture. So the simple thing is to apply a dorsal gutter splint. You need not have a ready-made splint like this. You can even make it locally, as I'll show you in the next example. So ice fomentation, NSAIDs, and splint the finger in extension for 2 weeks. If you are very sure that there is no fracture. If you are very sure that there is no fracture, splint it in extension for 2 weeks and ask the patient at the same time to do DIP joint exercises like this. This is another example. There was a fracture here, but this fracture was undisplaced. The finger is essentially stable. So this patient also can be treated like a blunt injury. You can see a swelling here. So again, this patient also is at the great risk of developing a PIP joint flexion contracture. So you make a local splint like this. I'll show you how it is made. And you take a syringe and just cut a 20 ml syringe can be cut into 3 parts. And 1 part can be used with padding as a splint. You can see that patient is doing DIP joint exercises. And that is the splint syringe. And that is well padded and applied on the finger. Now, invariably, as I've said, these patients present late and they have no fracture. The red lateral view also shows the finger having no fracture, but it is in flexion. So how do you know whether this patient is going to respond to a splint or not, or whether he's going to require surgery or not? So in this case also, there is no active extension. Flexion is always full. So patients are sometimes reluctant to take treatment. So the best or the simplest test is just try to passively extend the finger. If the passive extension is painful like this, that means that this patient is going to respond to a splint. You have to have two types of Kapner splints ready, with one with a medium temper and one with a hard temper. So you use a Kapner splint in this case, they will respond very well. They will stretch out. You have to teach them, you have to give NSAIDs. You have to teach them intermittent, how to apply the splint intermittently, then apply it continuously in the night for some time. And they develop very well. And they have a very good result. And that shows very good recovery. But I prefer to use a precautionary splint for 3 months, at least in the night, so that they don't have a recurrence of contracture. That's very common. The contracture can recur if you are slightly, if you are not cautious enough. So now this is an example, another example. I have just to highlight how neglect of these injuries can result into a horrible contracture. This was a doctor who neglected. There was no injury. There was, you can see, no bony injury. He had injury to the middle finger. He did not take, he did not splint it in extension, passive splinting in extension. You can see this injury in January. In February, the finger started flexing, but still he is not following the orders. And in 3 months, this was a uncorrectable flexion contracture of the PIP joint. And he had to undergo volar release and followed by splinting, and which ultimately had a good result. So the same example, delayed presentation, this presented after 2 years. At this time, when he presented 2 months, he was passively correctable, but he removed the splint. And at 2 months, 2 years, he presented with a severe contracture. Cosmetically is not acceptable, socially, functionally also is not acceptable. He cannot do anything with the hand, for which I do this method. You do a release of the flexor sheath and the volar capsule, volar plate, if necessary, volar capsule. Like this, you go on the volar side, you identify the flexor tendons here. Then you identify the sheath. Most of the cases, you don't require to see the volar plate, or you don't require to see the attachment of the volar plate on the neck of the proximal phalanx. Most of the time, the culprit is the flexor sheath, which is very tight. So in this case also, you can see that the tendons are retracted. This is the flexor sheath. The flexor sheath is identified. Now this is a magnified image. The flexor sheath is identified, and what you do is just cut the sheath here. You can see that the flexor sheath is cut on this side. The digital vessel is on this side, so it is very safe. So just cut the flexor sheath, retract the extensor flexor tendon on the other side, and cut the sheath on the other side also. And you can see that the flexor, most of the cases, 90% of the cases, the contracture gets released like this. You stitch the wound up, wait for about 2 weeks, let the wound heal completely, and then start him on exercises and continue the Kapner splint for about 3 to 6 months, and you will have a very good result. Like so. So this is the last part of the talk, which just highlights the case of a PIP joint dislocation. Now, these cases are very obvious. The dislocation is where the patient has a lot of pain. There is a gross deformity, very unlikely to miss on radiographs. Still, I would say multiple X-rays are required to know the proper diagnosis, whether there is an associated fracture. Generally, there is no associated fracture in this. The dislocations are very stable, and close reduction is very simple. It can be done in the OPD. But however, when there is a wound, you have to wash it and take adequate precautions and prevent hyperextension for 2 weeks. Now, this patient was unfortunately patient of a dislocation, but he was kept in straight position. So he got stuck in the same position. And you can see that there is a lax volar plate here. He is unable to flex. We did a sonography. It was reported as something else only, full thickness avulsion and all that. But patient was having a good profundus action. So we took a chance and gave him this splint. So this is the result at 15 days. That same splint which you saw previously. This is at 30 days when the patient is able to actively flex, but he does not have complete extension. And this is at 3 months with alternate flexion and extension. If you have time, I can go for last 2 cases. Otherwise, I'll stop here. So this was a very interesting case of untreated flexure dislocation. This was 6-month-old patient who presented with a cricket ball injury, and there was hardly any movement at the joint. So I opted to just attempt a distraction of this joint and just see the lateral views. It's actually lateral view is quite difficult to interpret with the fixator on. So in this case also you require over distraction so that you are able to slide the middle phalanx over the proximal phalanx like this. And again, you can see in the C arm that we have reduced the joint, but you have to reduce it in flexion only. All these joints are always stable in flexion. So this was the X-ray with the rubber band on. So rubber band is keeping in flexion, and then we removed it. And dorsal bump also, which was developed, has also resolved completely. And this is the result at 1 year post-op. This is completely done by closed means. No open reduction was done. No incision was taken. And this is 4-year post-op of the same patient. And that is the 4-year result. You can see joint is very well formed. There is no arthritis yet. This is a young boy, about 25. So we don't expect too much problems. So this was another very interesting case of a volar fracture dislocation, which is also very uncommon. Again, this patient again presented late. So this patient had the flexion deformity, but no further flexion or extension anyway. So this was also treated with only a distractor. And distractor was maintained for 4 weeks. At the same time, all these cases, when you apply a distractor, please ensure that the patient does a DIP joint exercises. And you can again see a very perfect central position of the pin. That ensures that the distraction also is proper and it doesn't cut out. And a patient developed flexor tendon adhesions in this case, so which was treated with Kapner splint passively, stretching the whole finger. And at 6 months, patient had an excellent result. And that is the X-ray at 6 months. So you can see again multiple X-rays. So multiple X-rays are the simplest thing to do of that same finger. So in essence, for all these PIP joint injuries, dead lateral view is very essential. Preferably take 2 lateral views on either side, from medial and lateral side. The lateral views in flexion and extension are helpful to ascertain stability. The PIP joint is always stable in flexion with a fracture dislocations or even with dislocations. So they are always stable. So how to give the traction, it depends on what method we are used to, what convenient this thing. Nail traction is good for very stable joints. Otherwise, you can give finger strapping as I've shown with a tape, or in uncooperative patients, you can use an extensor block pin, or with the dislocation or the fracture is sublux or the dislocation is subluxating. So if the joint is subluxating, you can use an extensor block pin. The PIP joint contracture is inevitable due to the flexion, and the flexion contracture can be treated with the Kapner splint. So 2 splints are required, basically a dorsal gutter splint and Kapner splint. If you master these 2 splints, I think all your PIP joint problems are over. The volar leaf fragment in a fracture dislocation, though it seemingly seems to be united, can be pulled out in most of the cases with external distractor. Open reduction gives good results in late cases. Alternatives are volar plate arthroplasty and hemate arthroplasty. The PIP joint contracture in blunt injuries should be prevented with a dorsal gutter splint. I thank you all for your attention.